And Dr. Matt Govil, who's an ED physician, has been with us for a long time. He has been giving this talk about ED management. So this is a continuation from what Mark has presented from, not the same patient, but how do you manage a patient from out of hospital cardiac arrest in the ED? Matt?
Good morning, everyone. As Dr. Laffey mentioned, my name is Dr. Matt Goebel. I'm the EMS Medical Director over at Mercy. It's my pleasure this morning to talk to you about ED management of out-of-hospital cardiac arrest. Unfortunately, I have no financial disclosures. I'm available for any of the vendors that are here. My objectives for you today, in terms of the two objectives for the block, I'm going to be talking more about sort of research updates and sort of what the latest literature is telling us about how we should be managing or can be managing these patients in the emergency department. And so I'm going to break that up into three areas. First, we're going to talk about updates with defibrillation. Then we're going to talk about IV versus IO for drug administration. And then we'll talk about management of electrical storm or refractory VFib VT patients. So starting with defibrillation, the elephant in the room that everyone is, of course, interested in is dual sequential defibrillation. So we have to talk about the dose of EF trial, which came out in the last year and has made a lot of ripples since it came out. So this was a Canadian study where they did they enrolled patients that were in refractory VFib. On the fourth shock, they were randomized to one of two strategies. Either vector change, which meant they went from anterolateral pad placement to anterior-posterior, or dual sequential, where they just added the second defibrillator and then they shocked them not at exactly the same time, but kind of one then the other. So this was, as I mentioned, refractory ventricular fibrillation, pre-hospital cardiac arrest patients. The intervention was vector change or dual sequential defibrillation, and the comparison was standard defibrillation. And their outcome was neurointact survival. The primary limitation for the study was that it was stopped early by the Data Safety Monitoring Board. Part of that was also sort of a practicality or a logistical thing. They stopped the study during sort of peak COVID in their region in Canada because their medics that were transporting all of the COVID patients to the hospital were waiting so long to offload their patients in the ED that they weren't able to get on scene to the cardiac arrest in order to randomize the patient by the fourth shock. So they were just like, look, we're not enrolling anyone. We already have a significant result. We're going to stop. So what did they find? Dual sequential significantly outperformed both standard defibrillation and vector change, both for survival to discharge and neurointact survival, with neurointact survival in the dual sequential arm being around 27%, which is really high. That's like the same, you're getting into the range of like patients that would be put on ECMO, like during cardiac arrest. Now, in studies that are terminated early, you tend to overestimate the effect size, so this is probably higher than it actually is, but still significantly better than what we're doing already. So how robust was the result? There's a number we use called the fragility index, which looks at the number of patients that would have to go from sort of one group to the other to break the result. So if 9 patients in the dual sequential group had the different outcome, then that would have gone away versus only 1 in the vector change. So the dual sequential result is definitely like more robust than the vector change result, but still was statistically significant. Now, these authors have continued to keep busy looking at secondary analyses of the data that they collected during the trial, because they have this huge treasure trove of data of all of the monitor strips and looking at exactly what was happening during the arrest and around the time of the shock in each one. And so they've looked at time in VFib. So patients that, at each pulse check, they might have been in VFib, but in between, they might have converted for parts of the time. And they found that, perhaps unsurprisingly, the less amount of time you're in VFib, the better you do. And that both vector change and dual sequential were associated with having, even though they were still in VFib at each pulse check, the patient was in VFib for shorter amounts of time using those other two. So it appeared to be associated with better survival. And then they also looked at shock refractory versus shock recurrent VFib. So that's the patients in VFib, we shocked, we converted, but then they went back into VFib by the next pulse check, versus we shocked, nothing happened, and they continued in VFib for the next pulse check. Dual sequential was better across the board in all groups, and then vector change was better depending on the subgroup. And again, these are all secondary analyses that they're trying to get more out of all the effort that they went through. And so it's raised a couple of very important questions. So is vector change better because anterior-posterior placement is better for cardiac arrest? And what about early use of these different defibrillation strategies? Like if we shock these patients on the first or second try using vector change or dual sequential, would we prevent them from having to get to the third or fourth shock? We don't know, but that's a study. That's an area of ongoing study right now, and something they're trying to tease out to determine when exactly we should be applying these tools. So as an EMS doc, I can't help but bring in a little bit of EMS spin to this. So I have to say, for anyone that's working pre-hospital, the state protocols don't specify pad placement. So if you're a Mercy agency, then you are certainly free to use AP or anterolateral. If you answer to Bay State, you'll have to ask them. But just, I am actually a medical director, but if you would go to Bay State, I am not your actual medical director. So just have to throw that out there. So the bottom line when it comes to defibrillation, anterior-posterior might be better than anterolateral, and dual sequential is probably better than both. And so my practice when the patient gets to the ED is I start with AP when it's practical. Sometimes it's not, but if I can, I start with AP. And then I'll go to dual sequential sooner rather than later, like essentially when it's possible. So another study that you didn't know we needed, IV versus IO. So IO access was actually invented in the 20s, and it became popularized during World War II for resuscitation of trauma patients. It sort of repopularized in the 90s with the advent of the EZ-IO, and then it's really sort of exploded since 2005 when it became part of the AHA guidelines for ACLS at that time. So the Paramedic 3 trial, which recently came out, was looking at all comers of out-of-hospital cardiac arrest, looking at IO first for your drugs versus IV first, and their outcome was 30-day survival. Some significant limitations to this study. They enrolled about 6,000 patients, but they had to exclude 4,000 because the patient already had vascular access by the time the research medic got there. So these patients may be systematically different from the rest of them because they arrested in a place where the response occurred quick enough that there was someone like on scene already compared to the research medic getting there. So there may be a difference in that subgroup. And then it was stopped early for low enrollment. So what did they find? No difference. Which I always tell my crews when they're thinking about when they're going to transport a patient is like, look, the epi doesn't work any better at the hospital. It's not like we have like hospital grade epi. We don't have like, the epi is not magic, right? We all know that if you give enough epi to a rock, you can get ROSC, but we don't know the role that it has in actually benefiting neurointact survival. So whether you give it IV or IO, it works just as poorly, okay? So my practice, because I'm working in the ED where my patients are on a stretcher at waist height with 360-degree access and good lighting, and I have a team of people, then we just swarm the patient and I use whatever we have available first. It's not like I'm resource limited like I am in the pre-hospital setting where I have to prioritize what am I gonna do, because we may only have one ALS provider on scene, right? And so in that instance, it may make sense logistically to do IO first because it's fast, I know I'm gonna get it and I can move on to the next thing. Moving on to electrical storm. So electrical storm is defined as a patient having more than 3 episodes of VFib or VT within a 24-hour period. And the thought in this trial was if the heart is too excited, maybe we should try to calm it down by giving a beta blocker. So this was a retrospective look at patients that received esmolol, 25 that were in VFVT arrest and that had 3 rounds of ACLS, including antiarrhythmics, epi, all that. They found 67 versus 32% sustained ROSC for patients that got esmolol, and 50 versus 11% neurointact survival. Small study, but an very interesting result for patients that are sort of like at the end of the treatment algorithm. Often that at this point in the ED, we're getting out to like 4 or 5 shocks. It's like, okay, what else can we do? We sort of reached the end at ACLS. I don't think giving more epi is gonna help. We've tried that a bunch already. So try esmolol. For this same patient population, patients that are sort of having these prolonged VF or VT arrests, there's also the stellate ganglion block. Stellate ganglion is part of the innervation of the sympathetic nervous system to the heart. So we can go in with a needle and inject lidocaine or another numbing medication like bupivacaine to tone down the amount of sympathetic innervation that the heart's getting and try and reduce the signaling that's potentially causing it, right? So it's similar to giving the beta blocker. We're trying to calm everything down. So this trial is 131 patients that received 184 different blocks. 92% of the patients had a greater than 50% reduction in anti-tachycardia pacing and or defibrillation. Some of the patients already had internal devices. Some of them they were on external defibrillators. There was only one case of local atastenic systemic toxicity, and I'll show you why in just a second, why that probably happened. And there were no bleeding complications even in patients that they were on anticoagulation or dual antiplatelet therapy. Now, this is why it can be a bit tricky. Those pulsating black parts are the internal jugular and the carotid. And then you're threading the needle right behind them to get to the nerve bundle and then inject your lidocaine or whatever else you're using. So it's a little challenging to do during a cardiac arrest, but if you're this sort of far out into the algorithm, you're sort of in a research-free zone of what your options are. In many places, this might be a patient that would be an ECMO candidate, but certainly I'm not going to be able to put anyone on ECMO at Mercy, but I have lidocaine, so I can inject that, I can try this. So to summarize, vector change and dual sequential defibrillation are emerging tools that we're still learning how to use, but they are very promising. We don't necessarily know where the best application of them is yet. IV, IO doesn't really seem to matter, use whatever. And esmolol and stellate ganglion nerve blocks are also emerging therapies for patients that have these sort of like super refractory cases of VF and VT. And I will briefly mention, just because they came out like this week, and it's something you might hear about in terms of the 2025 AHA updates, you'll probably hear a lot of people talking about the recommendations surrounding the use of mechanical CPR devices. So what you'll probably hear is that the AHA didn't recommend use of mechanical CPR, which is not saying that they recommend don't use mechanical CPR. What they actually said was there is not enough evidence to recommend using it across the board, and that it probably has a place in select cases where you may be resource limited, and it's certainly the only safe way to transport a patient. So it doesn't change anything. We knew that there wasn't necessarily a patient-oriented benefit to using, the Lucas device, but we know that there's a provider-oriented benefit, because it's sometimes the only safe way to do CPR, certainly only if you're doing it under transport. It's the best way to do it if you have a prolonged resuscitation or in a difficult area. But they encourage, essentially, if you are going to use it, you need to practice with it so you have minimal, off-the-chest time. So when you hear someone saying that, it's not that they recommended against it, they said there's not enough recommendation to do this across the board, right? We're not saying this is so great that you need to have like public access Lucas devices, right? Like next to the defibrillators. I'm sure as much Stryker would love that. But it's just that they're saying we can't recommend that for everyone. So I wanted to throw that in there since they came out like this week, and I know it'll come up. The QR code goes to a PDF of my slides if you want to scan that, and that's my contact information. Thank you very much.